Ladies and gentlemen, welcome to the 2023 IPF Forum. My name is Darcy Murdoch. I had a double lung transplant close to 9 years ago, and I lived with IPF from diagnosis to transplant was 3.5 years. So I'm happy to be here and share my experiences and pass on any knowledge that I can. But I'm here to introduce Dr. Alyson Wong, who is a respirologist at St. Paul's Hospital and clinical assistant professor in the Department of Medicine at the University of British Columbia. Her primary clinical and research interest is interstitial lung disease, or ILD. Her research focuses on the economic burden of ILD and the integration of health economics into clinical research. Please help me welcome Dr. Alyson Wong.
Great to see everyone in person and online. Contrary to what Fran painted earlier, we actually really enjoy coming to participate in this conference. It's one of the rare times that we could really bring together caregivers, patients, providers. So we're always very excited this time of year. My part of the patient journey is going to be focusing on ILD diagnosis. Okay. So I'll briefly go over, provide an overview of interstitial lung disease, and then we'll talk about the road to getting diagnosed. And some of the barriers that are experienced. And Rick really highlighted some of the things I'm going to be talking about. So interstitial lung disease occurs when there's any inflammation or scarring involving the interstitium. And the interstitium, I like to think of as saran wrap that wraps around all the structures of the lungs. So the airways, the breathing tubes, and then the air sacs. And normally this layer is very, very thin. And so when you have oxygen going into your breathing tubes, it transfers very easily into the bloodstream. However, when you have interstitial lung disease, this layer gets very thick and it prevents that oxygen exchange. There are over 200 different types of interstitial lung disease. And if we think about it simplistically and in broad strokes, they can be categorized into the following 3 groups. So it can be exposure related. So it's either a medication that you've been taking for a long time. It could be something that you've inhaled in your environment. It can be autoimmune related. So if you have an underlying connective tissue disease like rheumatoid arthritis or systemic sclerosis, or it can be what we call idiopathic, which is when we don't have a specific underlying cause. And idiopathic pulmonary fibrosis, or IPF, is the most common type of idiopathic ILD. So how is ILD first detected? So there are a few ways. So the first is that it's incidental, meaning there's no suspicion of interstitial lung disease and it's kind of an unexpected out of the blue diagnosis. So usually this is when people get testing for other things. So for example, maybe someone has abdominal pain and gets a CT scan of the abdomen or imaging of the heart, and it catches parts of the lung that is abnormal. We actually have a name for this. It's called interstitial lung abnormalities, or ILAs for short. And this is when there are features of scarring or inflammation in the lungs when a previous suspicion of ILD was not there. So ILAs formally require that there's abnormalities in more than 5% of any part of the lungs. And again, it's when we're not suspecting ILD. And interestingly, in population size, large cohorts where we follow people over time and see how disease presents and progresses, they've found that people who are over the age of 60, the presence of ILAs is about 2 to 9% of the general population. So not an insignificant number. And why do we care about ILAs? You know, they're not really causing symptoms. People aren't worried about ILD in these people. But what we've found is that ILAs can actually progress over time. So in those large population-based cohorts, over 50% of people actually demonstrated progression over 5 years. And this then leads to respiratory symptoms, functional impairment, and an increased risk of death. So risk factors for developing ILAs include increasing age, cigarette smoke, either current or past, exposures to other inhalational exposures, so air pollution, gases, vapors, and then some genetic factors. So very similar risk factors for developing interstitial lung disease. The way that we manage ILAs, it's kind of evolving right now, but the consensus is really based on a person's risks of progression. So things like the cigarette smoking, as mentioned, medications, if someone is going to be getting radiation therapy to their chest or thoracic surgery, there's certain features on the CT scan itself that can predict progression. If people don't have any of those risk factors, then we actually counsel people on minimizing exposure to these risk factors in future, and then just counseling that they be aware that if symptoms develop, then they should be reassessed. However, if patients have a risk of progression, have some of these features in the blue box, then they actually should be monitored probably for at least a few years to ensure that there's no progression. So that entails getting a breathing test and repeat CT scan within 1 to 2 years. The second way that ILD can be detected is through screening. So there's no formal screening program for interstitial lung disease, but there are diseases that are associated with ILD. So for example, systemic sclerosis or scleroderma. Scleroderma involves the skin and joints, but a lot of patients end up having lung involvement, so 65%. And it's actually the leading cause of death in systemic sclerosis. So oftentimes people with this disease, whether they have symptoms, respiratory symptoms or not, they should actually be screened for ILD. So that's another way that ILD can get picked up. Another is through this concern of familial interstitial lung disease. There is no formal recommendation on screening family members. However, in studies looking at familial ILD, they have found that about 20% of family members did end up having CT abnormalities. And if they had these abnormalities, typically they're those interstitial lung abnormalities, they actually had a higher chance of progression. So not 50%, but the 63% over 5 years. And then lastly, this is probably the most common way that ILD is detected is through symptoms. So cough and shortness of breath are the most common presenting symptoms. They're usually gradual in onset, and I don't have to tell you all how ILD presents symptom-wise. But the challenge is these are really non-specific symptoms. So cough, shortness of breath can be found in a lot of other more common respiratory conditions, such as asthma, COPD, even heart disease. So diagnosing ILD requires several different things. Obviously, the patient assessment is very important, looking for causes of ILD, screening for autoimmune features, drug and environmental exposures, for example, and then getting a high resolution CT chest. And I'll talk about that in a little bit more detail, pulmonary function tests, blood work, and then in some cases, surgical lung biopsies, but we really try to avoid this if possible. And Dr. Marinescu will provide even more detail on these tests. I will spend a couple slides, though, focusing on the importance of imaging in ILD. So it's not just ordering the test, but it's ordering the right test. So there's a lot of different ways that we could take pictures and image the chest. So for example, on the left, there is a picture of a normal chest x-ray where we see that it's a nice, smooth, dark appearance. And then someone who has interstitial lung disease on chest x-ray. And maybe there's a little bit more haziness, but it's pretty subtle and easy to miss on a chest x-ray. And then the CT scan really provides a lot more detail and can help confirm that diagnosis of ILD. So ILD should not be diagnosed with chest x-ray, and it really should be through a CT scan. There's another layer to this, though, because there's different ways that we can do CT scans of the chest. So there's something called the high resolution CT scan of the chest. Dr. Marinescu may talk about this more, but it's a way that takes more slices and images of the lungs in the way that it's reformatted. It provides a lot more granular detail. So this is a comparison of a standard CT chest compared to a high resolution, same patient, same time, same level of the lung that's taken. And you can see that there's a lot more detail provided on that right side image. The other important part of ILD diagnosis is the multidisciplinary discussion, or MDD. And this is where groups of different specialists come together and discuss complicated cases. So we've got our ILD clinicians and then our lung radiologists and pathologists. And the discussion amongst these specialists has been shown to increase the confidence in an accurate diagnosis to the point where we actually can avoid some of these more invasive procedures like a surgical lung biopsy. So delays in diagnosis are unfortunately common and lead to poor outcomes. This was a study in the US looking at 129 patients with IPF, and they wanted to explore delays and outcomes in patients who experienced delays. So they found that the average delay was just over 2 years from the time of developing shortness of breath to being seen at a tertiary care center, so a place that provides ILD care. And what they found is when they broke down the duration of delay, so less than 1 year up to more than 4 years, that the rates of mortality actually increased, which is not surprising. And so we know that increased delays are associated with a higher chance of death. So this was a great article that looked at the different components that could be contributing to these delays, and we'll go through them. So from a patient perspective, some of these delays include that shortness of breath and cough, which are the main symptoms initially in ILD, are common in other conditions. Maybe you had the seasonal allergies and it's just a lingering cough, and it's very easy to brush off. Or maybe you saw a physician and they thought, well, let's try some puffers, and maybe it's asthma, common things being common. So all those things can kind of lead to a delay in the final and correct diagnosis. These type of barriers can lead to challenges such as anxiety for patients, and maybe people develop symptoms to the point where they have to come off work and go on disability. So there's a lot of challenges and poor outcomes related to these delays. This was another large survey. It was an online survey performed in the US, and 600 people participated, trying to better understand the patient experience in getting diagnosed with ILD. So the most common symptoms were shortness of breath, 77%, cough, and then followed by fatigue and weakness. And 72% of the respondents actually initially thought that their symptoms were due to increasing age and just getting older. And so it is really easy to brush off these symptoms. The average time from initial symptoms to the first doctor visit was 3 months. And 30% of people reported that they had 4 or more visits to their primary care physician before being referred to a specialist. Misdiagnoses, like Rick was mentioning, are unfortunately common. And so 55% of people had 1 or more misdiagnoses before being diagnosed with ILD. And over a third of people actually had 2 or more misdiagnoses. And this led to a delay on average of about 11 months. So the incorrect diagnosis is common, and it leads to delays in the final ILD diagnosis. The most common misdiagnoses are respiratory conditions that are common. So things like asthma, pneumonia, bronchitis. From a primary care physician, some of the barriers could include just perhaps not having an awareness of ILD being the first thing that pops in someone's head. If you're seeing 20 cases of asthma in a month compared to 1 case of ILD in a year, if someone's presenting with the same symptoms, shortness of breath, you're probably going to think about asthma first. The very small table on the right-hand side is just to emphasize that there are a lot of conditions that can lead to these symptoms. So this is just a list of conditions that can cause shortness of breath. So a lot of things have to be kind of worked through in order to get to that final ILD diagnosis. And then in terms of barriers from the local hospitals and respirologists, having access to the right tests is huge, and then access to specialists as well. And I think in BC and in other places around the world, it is really hard to get connected to primary care, let alone a specialist. Within BC, we're geographically very spread out, and a lot of communities don't have access to respirologists. And these respirologists are actually the people that tend to make the ILD diagnosis. So 88% of respondents in that online survey said that they were diagnosed through their respirologists. And then lastly, in terms of diagnostic barriers from an ILD center, It's not so much that we have diagnostic barriers, because by the time people reach our center, they've been diagnosed with ILD. But it's about providing an accurate diagnosis for those complicated cases, having them reviewed at the multidisciplinary discussion, maybe even needing a surgical lung biopsy. So 68% of respondents found that the ILD center provided the clear diagnosis. So it's kind of providing as accurate and the best understanding as possible to patients. In terms of ways that we can address these barriers, so I think overall, increasing the awareness of ILD amongst patients and providers, making sure that we have access to these tests that are necessary for diagnosing and monitoring ILDs, and then ensuring that people have access to specialty care, both the respirologists and ILD centers. I will say locally, we have tried to improve ILD diagnosis. So we have this multidisciplinary discussion in Vancouver between VGH and St. Paul's. However, we also make it available to any respirologist in British Columbia, so they can refer cases for us to review without actually needing to meet patients. And this allows patients throughout BC to then have access to this multidisciplinary team without the need of physically coming to our clinic in Vancouver. And this, helps to reduce wait lists and the logistical barriers of being reviewed. And we have published on the impact of this model, and we found that the number of confident and accurate diagnoses improved. So people came into the multidisciplinary discussion without a diagnosis, and 44% of those cases ended up with a confident diagnosis after review. In addition, the diagnosis was actually changed for 40% of the cases after being reviewed. So again, improving the accuracy of diagnosis. So to conclude, the initial symptoms of ILD are non-specific. Misdiagnosis is unfortunately common and leads to significant delays in correct diagnosis and then ultimately the right treatment. And the ways that we can improve this is increasing awareness of ILD, access to tests, especially that high resolution CT test, and then care with respirologists and the ILD centers. Thanks.